Welcome to School of Rock, where complex PCI meets expert opinions.
All right, so let's talk a little bit about IVUS assessment. So once we've treated a vessel, how do we assess it? So we're going to look here at some cutting balloon technology that Salman will talk to you a little bit later. In the top, you can see we have some eccentric calcium there. In the bottom, we've got concentric calcium. But after the use of a cutting balloon, on the after side there, you can see fractures in that calcium, both in the eccentric calcium as well as in the concentric calcium. And this is what you're really looking for on intravascular ultrasound after you use a calcium modifying technique. You want to see that you have actually modified the calcium, because if you haven't, you're not done and you're going to need to pick another device. So what about scoring systems? These days we've got scoring systems for almost everything. So we've got one for IVUS and calcium too. So if you see angiographic calcium, all right, there's intravascular ultrasound. Do we have an arc greater than 270 degrees? Yes or no? And if it's yes, this score would suggest that there are several things that you can look at that are going to predict your need for calcium modification and stent under expansion. So calcium greater than 270 degrees and greater than 5 millimeters in length, right? So 5 millimeters doesn't seem like a lot, but it would come when it comes to calcium, the longer the length of calcium, the more you're going to need to modify that vessel. Is there full concentric calcium with 360 degrees? Is there a calcified nodule? And we're going to talk about this a little bit more, because I think this is one of the most difficult situations to deal with sometimes. And then what is the vessel diameter? And if it's less than 3.5, you're going to be at higher risk for stent under expansion without modifying the calcium. So this score would suggest that if your score is 2 or over, that you should at least consider atherectomy or some other method to modify that calcium prior to stenting. So here we're going to just show you an IVUS scoring system. So you can see the start of the calcific segment, and you can see the end of the calcific segment. So we're definitely more than 270 degrees there, not quite 360, definitely longer than 5 millimeters. And we don't have a measurement here, but my guess would be that that might be 3.5 millimeter vessel or just under. So we've got at least two parts of our scoring system here that would suggest that we definitely need to use calcium modification to prevent stent under expansion. And again, just showing you these angles, less than 90 degrees, less than 180, 270, and then again, a full thickness calcium all the way around that far right vessel at 360 degrees. So again, you see the brightness of the calcium, you see the shadowing behind it. Very, very characteristic look of calcium on intravascular ultrasound. And again, morphology, concentric, is it eccentric, or is it nodular? And we'll speak to the nodular calcium a bit more as we go forward. So just to wrap up with intravascular ultrasound, I would say 100% angiography underestimates calcium. I've seen this over and over in my own career, and I'm sure you have too, Salman. Intravascular ultrasound, hands down, helps us determine exactly what that calcium looks like in the vessel that we can't see angiographically. And then there are some scoring systems that we can use to determine whether or not we need to modify that calcium. I feel, as I use more and more IVUS in my career, I don't really use scoring systems a lot. I don't know about you, Salman, but if I see calcium, I generally modify calcium. The last thing I want is to have rotor regret or shockwave regret, or, having a balloon in there and, God forbid, getting a stent in there that I can't expand.
Right. No, I agree. So I think if I can just sort of give you sort of my version of this slide, I 100% agree with you. I think the bottom line is this is the mantra, or this is the philosophy of the chip operator, or this is what it should be in 2025, right? So angiography is a two-dimensional system, two-dimensional technology or technique. The problem we're trying to solve is in 3 dimensions, and you need a 3-dimensional version. And so where you fill in that gap with the missing dimension is the IVUS. So or OCT, but for the purposes of this talk, we're talking about IVUS. So definitely, if you're solving a three-dimensional problem, you need information in all three dimensions to make the best choices. The second thing is improves clinical outcomes. And again, calcium is just a surrogate for the complexity, right? There's bifurcation, there are dissections, there are other things, there's expanded stents. And what IVUS really does is more than tell you about calcium, it tells you about how to then treat, where to deploy the stent, how to do the bifurcation. Is your bifurcation adequate? Is stent expansion adequate? So it's more than calcium, it's more than the scope of this talk. But as a tool, IVUS is not only a diagnostic tool, but it actually helps you with the therapeutic aspect of therapy planning. And then finally, I think the scoring systems are a bit like sort of the protocols or some of these sort of, for example, the hybrid algorithms that we have. These algorithms set a framework. You go through them slowly, you learn them, and then you apply them until they become innate nature. So I don't think anyone stops to actually do these scores, because ultimately the score becomes part of how you reflexively, the human brain makes habits. The score becomes your habit. So do I stop and measure the calcium every time and make sure it's at least 5 millimeters? I do not, because after doing a lot of these, you realize what needs to be done. So again, this, I think, slide summarizes the philosophy of chip and calcium management in 2025. This is what the goal should be.